Sorry. Uh, in the beginning of your slides, you assume that the posterior instability it's due to hypoactive and hyperactive muscle. So the reason of the posterior instability is the hypoactive muscles. Anything proof that, any evidence? I'm not sure. Like, is that real cause of posterior instability? And because if it's the real cause, I would understand that that device would help. Yeah, please.
I hope I understood you correctly. So there is some evidence that shows which muscles are hypoactive in this kind of functional shoulder instability. Andrew Jaggi from Great Britain, they did a great job with EMG studies to show which muscles are not active. And I truly believe in it because the success is just this great. And I actually disagree with what was said earlier. The subscapularis does not prevent from posterior dislocation. It's the infraspinatus. If you contract the infraspinatus, this pushes the shoulder to the front. And if you contract the subscapularis, it pushes the shoulder to the back. So with these posterior instability patients, once you activate a strong contraction of the infraspinatus, they're not able to push out the back anymore because the infraspinatus contracts and pushes it to the front. So there is some evidence, but it's very difficult to obtain EMG analysis while you're moving. It's easy while you're calm, but when you're moving, you get a lot of artifacts. So it's not that easy. You can do it with fine needles, of course, but then as observer with fine needles, you already influence the measurement and the activity of the patient. And with surface electrodes, you get a lot of noise, unfortunately.
Philippa, what's the role, in your opinion, of anatomical elements, anatomical factors, like glenoid concavity or glenoid version or tissue quality, soft tissue, I mean?
So I think they, of course, interlink, because what we saw is this treatment works very good in patients that have a normal MRI, obviously. And we also have some patients that have the same pathology, but they actually have a glenoid dysplasia, like you said, a flattened glenoid with this poor posterior wall of the glenoid. And we saw that it's more difficult to treat those patients. So the effect is less in these patients. And the question is, where does it come from? And I find it quite interesting because if you think this is a pathology that is generated quite early and it's mostly not noted for many patients, it might as well be that some of our dysplasias also come from a posterior instability kind of situation. We have to look at that more closely in the future. But I think, of course, the more glenoid retroversion you have, the more difficult such a problem will be to treat. And in that case, it's truly a combination of functional and structural. And then I would go for surgery plus functional training, and not one of those alone.
Thank you, Mr. Moroder, for the excellent talk. And I'm Senthil, I'm from Stanmore. What we're doing is we identify the hyperactive muscles and give Botox injection. So that acts for a few months, and during that time, we managed to push in with intensive physiotherapy. We also use muscle stimulation. So we've been having excellent results, but thank you for this new concept. It's very interesting.
The Stanmore group is very good. They did a lot of groundwork for that, a lot of ground research, and we really appreciate, because you really set the first step towards success in treating these patients. The only thing I say with Botox, I showed you positional instability. These are patients, they raise the arm and they fall out. You know, the shoulder pops out while they are moving. Those are mostly patients, in our opinion, that are caused, this instability is caused by hypoactive muscles. The ones with the Botox injections, we do that as well. We do it mostly for the non-positional type, that at rest can pull the shoulder out mostly to the front just by mere contraction of the muscles, maybe pect major. And there we also try the Botox treatment, which is, in our hand at least, a little bit tricky. It shows some success, but not, unfortunately not in every patient. Thank you.
Thank you.